Well, hi, everyone. I'm Maura Ruzhnikov. I'm a clinical neurogeneticist at Stanford, and I see our leukodystrophy patients along with Keith Van Haren, who's also here at Stanford. And I've been leading the diagnosis CPG group for a couple of years now, so I was just going to really quickly talk about what we've accomplished and then the ideas we have moving forward. So just to super quickly recap, the first project we did with me on board was to create a case-based review where we tried to highlight some of the earliest signs and symptoms of leukodystrophies. We highlighted several cases that were real cases that we had somewhat altered to make them kind of palatable to any kind of reader. Eventually, this will be in an issue of Pediatrics in Review, which is kind of very often read by especially trainees in pediatrics, which we thought was a good group to reach out to. It also has like a very friendly format for people to use as a reference. There was a big team. We had kind of a core writing group and then the rest of the diagnostic working group who gave input on that manuscript, which we've talked about a couple times now, so I won't go into detail. It was actually accepted for publication in January, but for whatever reason, it's taking forever to be in print. So I apologize for that, because I know I get emails every once in a while asking if it's out yet. So I've been in touch with the editor, and it will eventually come out, but we're still waiting. But one thing that we still had remaining to do for this specific document was to make a parent companion. We'd kind of hedged and hawed about it initially while we were waiting for acceptance, and also a few discussions about whether we should or should not do that, just because it was a little different than some of the other CPGs, but I think it's something that we do want to do. So that's one piece of work that we have to move forward with in the near future. And as soon as this eventually comes out, I will update everyone. And then in Atlanta, at the last Hunter's Hope meeting, we had what I thought was a really productive brainstorm where people came up with ideas about where the diagnosis group could go from here. So one that really resonated with people was for us to create a questionnaire, actually really similar to the one that was done for Krabbe newborn screening, which is kind of to utilize our community to better hone in on this question of what are the earliest signs and symptoms, kind of what that early both diagnostic odyssey, but also just kind of care odyssey is. You know, what's the first thing that parents see versus doctors see? How do you eventually get to a provider? Things like that, which I'll get into in a moment. We also talked about maybe creating a series called something like When It's Not Just, where we would pick a common symptom, like say colic, inattention, trouble walking, you know, something that could have a pretty broad differential and kind of highlight when you might think about something more serious or specifically a leukodystrophy. We also talked about something like a position statement from Hunter's Hope to kind of push, you know, we still, unfortunately, in 2020 have a lot of trouble getting genetic testing covered for patients, especially in a timely manner. And so would, you know, putting out like a Hunter's Hope approved position statement be helpful. We had talked about looking at existing resources on the internet and apps, making sure our leukodystrophies were well kind of represented. And then other things we've talked about are case of the week pieces. So just presenting a case, but maybe not to the more typical genetics journals where we often will find rare diagnoses, but what about things like nursing publications, physical therapy publications, you know, things that we don't see as frequently. You know, how else could we kind of spread the word and bring awareness to thinking about leukodystrophies so it's not missed in these different areas. And then lastly, we had discussed a little bit about adding diagnostic resources to the Hunter's Hope website. So making sure that people know about different free resources for testing, things like that. So all of these had some degree of excitement, but we have to start somewhere. All of these things are kind of a lot. And so recently we thought that a good place to start may be the questionnaire. And let me see. So the idea was that we could build off the recent Krabbe questionnaire that was actually presented yesterday, so that's helpful. And the idea would be that it would be a really carefully curated list of questions that are specifically aimed at better understanding the experience around very early signs and symptoms from the caregiver perspective. So, what's the first thing you noticed? What prompted a referral to a specialist or for you to go see the doctor? Did someone else point it out? The timeline to those different aspects. We could also get a little deeper here, but of course we don't want this to get too long. But what was your experience related to these different factors could certainly come up. Diving into this a bit more, things that are really nice about sending out a questionnaire like this is that it's relatively simple. Once we decide that we really like our list of questions, it's one point in time, so we can kind of send it out and get it done. And also that we have a potential to get a really large sample size and make some meaningful, hopefully, conclusions by including all leukodystrophies instead of focusing on just one. That also gives us a chance to include some of the more rare, kind of rare of the rare leukodystrophies that aren't always represented, which might be nice. Cons, of course, are questionnaire fatigue. How often can we send things out to the same people, which I, am sensitive to. But we did get some feedback that a lot of people, would fill out anything if it meant that we would learn more about leukodystrophies. And so a potential con. And then the other thing, I think caregiver reported data is very meaningful. Sometimes we get a little bit of pushback related to that in terms of publication and feeling it's one-sided a little bit. On the other hand, often the caregiver experience is not reported on, and so it does feel meaningful to do this sort of thing. Interestingly, while I was making these slides, I had gotten a kind of update from Twitter that the Child Neurology Foundation is sending something out about the diagnostic odyssey from the caregiver perspective, kind of at large, so for all neurological disorders. So I think this idea is certainly one that people are thinking about right now, and so this wouldn't be too off the mark. So for this next step, I started a rough draft of the questionnaire, but I definitely don't want this to be a questionnaire, that serves only myself. And I really want other people's opinions, and I want people from different areas to be able to weigh in on what we specifically ask. So, caregivers, neurologists, and others. The diagnostic group has been, interesting because we kind of ebbed and flow as to what our focus is. So I wanted to make a little plug for us. If this really resonates with anyone, to please email me. I, of course, will also send out after this meeting an email to those who are listed as part of the diagnostic CPG right now to see, who this resonates with the most. But I would love to hear from people if this, really strikes a chord with you, because I think, again, what would be helpful is to have a nice small core to really think about this questionnaire and make sure we're asking the questions we want to ask before we blast it out. And also make sure it's in line with the missions of Hunter's Hope and all of our families. And then I did just want to touch on one more thing, which is the idea of, highlighting what resources are available is something that's relatively easy to do and could almost be like a side project. So, something I do in my spare time is think a lot about how to get people access to genetic testing. And so in that vein, I do have a free genetic testing resources component on a website, on an organization that I help run, which is the Little Zebra Fund. And so I just did a little screenshot here. We had to be really vague because if you get too specific about different opportunities, you do need to get kind of buy-in or clearance from each lab, because if you start putting in things like logos and links and explanations of the tests, it has to kind of jive with their messaging. So we left this really vague on purpose, but we certainly could do something where we specifically mention the opportunities for leukodystrophy. So a good example is that Invitae has a sponsored program for a multi-gene panel for the lysosomal storage disorders and things like that. So I think it's just something for us to think about as like a smaller, easy project to move forward on. And with that, I will ask if anyone has questions, comments, ideas, thoughts. If you like or hate the idea about where we wanted to start. I'm always open to any kind of feedback, and definitely would love for some people to jump into this idea with me.
Great. Thank you so much, Dr. Ruzhnikov. It looks like Dr. Mallack isn't at his, or Mallack is not at his desk. He was going to go next. Oh, there you are. Okay, good. All right.
I'm
So
totally here. Actually, Maura, when she told us about the little zebra fund, I just slid over to my other computer to email our genetic counselor. They're like, oh my God, we have more resources.
that's
I
great.
agree. It's extraordinarily difficult at times to get appropriate genetic testing for patients. So any resources that may be funded or at low cost are invaluable to our patients.
That's great. Well, please continue, everybody, to put your questions in the chat. And we'll try to get to them at the end of the session. But for right now, I'll turn it over to Dr. Mallack.
Right. So I'm going to share my screen and go through a couple things here. So this is part of the talk that I gave back in the winter, just before COVID. Flew back and everything went into lockdown, and New York City has never been the same since. So I'm not going to go through the background of what I spoke about earlier in the winter. But what I will do is just sort of review what we're looking to do. So we as a group, I'm part of the Neurology CPG work group. There was multiple sections that were, of course, parsed out and authored and then recompiled. Our manuscript was just accepted to the Journal of Child Neurology a month ago after extensive reviews and revisions, and we've learned a lot in the process. And one of the major things we learned was that there's just not a lot out there. And so when we were trying to provide evidence-based guidelines with lack of evidence in the circulating population of publications, you know, we then have to start to do something to fill those knowledge gaps. So it was a very good learning experience, I think, for our group. Thankfully, we were able to get some of our work published. But what grew out of that was a question of, well, what can we tackle and look at to help fill some knowledge gaps? And a very straightforward thing in pediatric neurology is seizures. It's you know, outside of the leukodystrophy world, seizures and epilepsy or something like that. So we decided to start to work on a project where we can characterize the prevalence of seizures and epilepsy and try to get a little more granular about what do seizures and epilepsy look like in the leukodystrophy population. So the aims were, we want to estimate the prevalence of seizures and epilepsy in patients affected by leukodystrophy. If we get enough numbers, can we break down the prevalence of seizures and epilepsy per leukodystrophy? And then, like I said, become a little more granular with respect to therapeutics and understand when seizures occur, et cetera, et cetera. So not just large overarching numbers, but some things that are a little more detailed. So this is the study timeline, and I'm actually just going to go. Let's see. So this is our data collection form, which we did through REDCap. So we created this form where people from multiple institutions can essentially just go through this form and fill one out per patient, and it dumps into a central database. And this was designed after a couple working group calls with a lot of people in this meeting. You'll see some of the treatments listed here, other treatments. Importantly, what were the EEG findings? Can we start to characterize what types of seizures and epilepsy we see in the leukodystrophies? And again, we get enough numbers per leukodystrophy, and then some extra information. So I ran a cut of the data this morning, and I promised you guys we'd show some data this summer. So these are preliminary results. These are sort of the bigger numbers, not too granular, but some exciting things to look at. So 5 institutions have participated so far and dumped their data in for a total of 335 patients, which is a respectable number to analyze. The median age across all leukodystrophies of the overall population was 8.8 years old. We have kids from birth up until 25 in the study. And so the overall prevalence of seizures, so out of those 335 patients, 109 have a diagnosis of a leukodystrophy and have reported having at least one seizure, so about a third. And the median age at first seizure across all leukodystrophies is 3 years old, so from right after birth to 22. So if you break it down by leukodystrophy, we'll look in the top left corner here. ALD makes up a sizable, about a third of the population. We have a couple of iCardiac Gutierrez patients, but if I have you look over on the right column, so leukodystrophy or leukoencephalopathy of unknown etiology makes up, and also, essentially the second biggest proportion of patients. And this is sort of reflective of what's been published just in terms of undiagnosed leukodystrophy or leukoencephalopathy. Dr. Vanderver at CHOP has done a lot of this work trying to identify and uncover and molecularly characterize this population of patients. But what she's found and what's been reported is that sometimes no matter how hard we try, we know that patients have a leukodystrophy or a leukoencephalopathy that we can't, at least right now, molecularly characterize. So it makes up a sizable portion. MLD makes up about a tenth of the patients so far, and then you can kind of peruse down smaller subpopulations. But a lot of the major leukodystrophies are at least represented: Alexander Canavan, Frabbe, PMD, KSAT, Spanish. So out of the 109 patients who have seizures in the cohort, like I said, it's about a third. The overwhelming majority of them are neurologically symptomatic. They have a symptom other than seizures or epilepsy, spasticity, hyperreflexia, something outside of seizures itself. Whereas only 5% of this population are neurologically asymptomatic. So it kind of tells you about something about clinical management and expectations in patients with seizures. So of the 109 patients with seizures, 14% had one. About a third had multiple seizures but don't actually carry a diagnosis of epilepsy. And about half actually have a diagnosis of epilepsy. And we see a history of status epilepticus, so if there's any epileptologists in the group today, this is a really important piece of information you can expect a not insignificant amount of patients to experience status, which can be deadly. So far in the data, about 10% of the study population reported an actual epilepsy diagnosis. And the vast majority of patients with the leukodystrophy fall under the focal or partial epilepsy symptoms. So CPS, localization-related epilepsy, partial epilepsy, multifocal epilepsy. The first three are sort of the same, are very similar ways of talking about the same thing. 28% of patients had a generalized epilepsy disorder, 12.5% had multiple seizure types, and then we have actual epilepsy syndromes then for 3 patients. So infantile spasm is a bad brain epilepsy that affects infants. It's very severe but treatable with high-dose steroids or ACTH. And then one patient had Geovanny syndrome, which is a refractory type of myoclonic. Importantly, we have EEG data on 113 of the 300 some odd patients. Out of that 113 patients that we had EEG data on, 72% showed abnormalities. And this is interesting, about a fifth of those patients who have abnormalities on their EEG don't actually have a history of a clinical seizure, whereas almost 80% of patients do have a history of seizures. Again, helping with clinical management and setting expectations that for general child neurologists, epileptologists, you can have a leukodystrophy, and we can expect you to maybe see some, some abnormalities on EEG without actually having a diagnosis. And in terms of characterization of EEG abnormalities, we broke down what we call slowing between diffuse or generalized slowing, which is about half the patients that had an EEG abnormality. We saw focal slowing in about 27%. And then in terms of epileptiform or abnormal signals that tell us that your brain is irritated and you're either predisposed or actually have a history of epilepsy. Faulty multifocal made up about 40%, and then generalized epileptiform think that's my last slide. So thank you to the groups that have participated. We are still going through the IRB process with a couple of institutions, and as those remaining institutions come online, they'll dump their data in. But I think kudos to Hunter's Hope for getting us together and providing a space to have these phone calls and plan this out, because this is a relatively rapid turnaround for a study that's going to produce hopefully 400 plus patients. So I'll take any questions or we can pop in the chat.
Great. Thank you so much, Dr. Mallack. For everyone who's presented so far in this session, there are a couple of questions in the chat if you guys want to address them there, because I don't think we're going to have time at the end. So please just direct all your questions to the chat and hopefully the speakers can answer them there. Okay, up next we have Dr. Giovanni Perez, who's going to give us an update on the respiratory CPG.
Everybody, let me just give me 1 second. Can you see it?
No.
All right, something. I'll give me just 1 second.
Do you want us to go to Catie next and then let you
Sure.
go? Okay. Catie, are you ready?
Yep, I didn't actually realize I was presenting, but luckily I can always talk. Okay. So I realized that this morning that you could call on me. So I'll hold on 1 second. So I'm just going to quickly show you what we did. So you want me to show you or you want me to talk about the parent coordinator, right?
Yeah, just a quick overview for
Quick
today.
overview. Okay.
Yeah.
So we are pretty much hopefully done with our family companion version of the of the family version. And so I sent that to Anna if she wants to share it with the larger group. And then we also have a family or a kids companion that's also pretty darn close to being done. And so we just really need some more families to send in their stories. And then I hope we'll have that done by the end of the summer.
Can you talk a little bit about the neurology family piece, just how you guys put it together? And
So the family piece, we put it together more to be online. And so it's not meant to be a single document that one would print. And so in the original paper that's, I think Eric said has been accepted, we focused on four symptoms: the pain, sleep, seizures, and cognition. And then we defined leukodystrophy based on how symptomatic a child was. So for the family companion, instead of having 4 levels of how symptomatic someone is, we just have asymptomatic and symptomatic. And I think we originally stayed away from asymptomatic, but I think now in light of COVID, everybody knows the word asymptomatic. So it's asymptomatic and symptomatic. And so for each of those 4 symptoms, we have both an asymptomatic and a symptomatic handout that parents could print.
great. Well, we hope to get that on our website soon. I know the neurology group was the first one to finish their family piece. So we want to share it with all the other CPG groups. It turned out better than I could have ever hoped for. So thank you, Catie, for all your hard work on that. And she'll talk more about that.
I just want to say, really, Sunshine Wagner, I don't know if she's on here, but having a parent that was willing to go through and rewrite everything to have a single voice, she deserves a lot of credit. She did an awesome job.
Well, it looks great. So Catie will talk more about that and the kids CPG tomorrow. afternoon.
And Anna, hopefully the treatment family CPG too is in the final works.
Yep, it is.
Awesome.
Yep, great.
I'm not going to present the kids. We have kids presenting the kids.
That's right. So we'll hear about that tomorrow. Okay, Dr. Perez.
All right, let's do this. All right, can you see them now?
Yep, they're there.
All right, perfect. So in any case, it's nice to see everybody back. There's been a lot of transition and changes within the respiratory group. There's probably like 4 people that, including myself, that we moved to like different sittings at different programs. So we had a little bit of like in the struggle trying to get everybody together, but we finally have all of the parts together, and I'm hoping to send it for like a submission for a journal within the next few weeks. So I just moved to Buffalo. It's going to be 6 months ago. We're probably going to be like those 3 months with COVID has been crazy. But in any case, so what we initially talked in the last meeting, remember, is that we're trying to make our guidelines that will remain true to the needs of like the foundation and to the parents and the family, and making sure that at some point we'll come out with we're going to try to use like more lame terms and not very complicated terms. So the parent guidelines, they are still in process. I'm trying to figure out from the big list of people that we initially had, who is actually committed to continue to work with us. So there's been a bunch of emails going out between Anna and myself over the last probably 2 months. And there's been a few people that they move and they are in different roles, so they might not have a lot of time to continue to work on some of these parts of the guideline. So what our guidelines basically consisted of everything that will affect the respiratory system, which is again, is swallowing function, gastroesophageal reflux, nutrition, drooling, airway optimization, and then home-assisted ventilation or sleep disorder breathing, and a part of the team-based care. So I'm just gonna go through like very quick throughout these. So with the swallowing dysfunction, we had Laura Ball that was driving these. Now she is in Mississippi. She moved out from DC probably like around 8 months ago or more. So maybe looking at like what tools can we use, the speech therapies, the radiologists, but what kind of studies are probably going to be recommended between that, the video fluoroscopy and so on. And then the management of like doing like a combination of oral versus tube feeding, and then creating some tables that will be helpful for providers to figure out what would be the best option. Same for gastroesophageal reflux disease, what are the risk factors, the clinical signs, what is the role of actually being more invasive, like getting an impedance pH probe, like doing endoscopy, and then what is the role of management between supportive medical or surgical, including enteral foods, tubes, Nissen fundoplication, and so on. From the secretion management, again, is trying to understand there's a scale and trying to come out with a different scale for secretion management. What kind of like medical treatments we could potentially use, in particular paying attention to some of the side effects. Surgery, there is a new procedure that started recently in nationwide children's, and we're exploring to do that here in Buffalo, that instead of ligating the glands, you can kind of like embolize the glands, and is a non-invasive procedure relative to like the ligation, the surgical ligation of the glands, which I think is going to be very helpful for in particular this population. We talked with Chad initially about like suctioning. A lot of parents didn't have an idea of like how much is too much suctioning, how deep, how frequent, and so on, and address those aspects. Airway clearance, which is very important. If we need or not pulmonary function test, depending on the kid, what kind of pulmonary function test to assess the muscle strength. What about mucus mobilization, the role of a cough assist device, doing manual chest PT versus using a vest device, and again, the role of suctioning along the same ways with airway clearance. Then the sleep disorder breathing, when do we need to order in a sleep study? I'm glad that we just briefly heard about like the data from like seizures, like looking into some of these sleep studies with the seizure montage to see there might be something related with the sleep and changes in breathing. And then the management, if there's a role or not for like a TNA, removing the tonsils at the adenoids, the recommendations for non-invasive ventilation, either by a bi-level ventilator or BiPAP, or what is the role of invasive ventilation via tracheostomy, and what are the potential complications of each one of them. The same thing with nutritional optimization, how we can improve like the nutritional aspect of kids or younger adults, looking for specific formulas or looking for a combination of oral and enteral feedings. And then more than anything, trying to improve the team-based care. So looking at the role of the pediatricians, how to communicate with the pediatrician in the community, and try to have like more than a multidisciplinary approach, more like an interdisciplinary approach where everybody's talking and providing recommendations, not in silos, but more like together. Something that we struggle is that there is not a lot of information about the respiratory implications of patients with leukodystrophy. So there is just a little bit of information and data out in the literature. And I'm sure that this is the same for a lot of other problems or for other subspecialties. So what I'm trying to do next is to, the same way that the data was gathered from the, for the seizure perspective, try to do something like that from the respiratory perspective. It is very hard to find any evidence for any recommendations, in particular for leukodystrophies. Most of the data, most of the information that we had on our guidelines is like coming from other neuromuscular disorders that in some sense will share some of the physiopathology with like either spasticity or other central nervous system issues or with hypotonia. But there is not a significant amount of data out there. So it will be great if by using the Country Scope and LCN, we can create some kind of like a sharing data center specifically for the respiratory issues that these kids go through. Again, there is some controversies depending on who you talk to about the role of invasive mechanical ventilation. In particular, failure tends to happen when there is also a significant amount of like perhaps CNS disease. And then there is this controversy about like going forward or not with an invasive mechanical ventilation. So there is not a lot of data about like parents' perspectives, community and other pulmonologists or other centers. So it will be very interesting to gather that data. So the next time that we meet or the next setup of guidelines or updates will be based more on data than just extrapolating from other disorders.